guys, before I get started today, I want to talk about my visit to my doctor. So I see Dr. Leigh St. Petery. This isn't a commercial for her. I'm just telling you how I take care of myself. She is a DO. She practices functional medicine. She's moving offices, so she wouldn't mind me saying this, but she's in a very small town, a very inconspicuous office, and she is just doing amazing things out of this place. And it's also in a very rural, somewhat lower socioeconomic part of, like, on the outskirts of Birmingham. So to see her in an area like that and to be educating patients who typically, I mean, a lot of her patients come from a Medicare, Medicaid kind of economic bracket, and a lot of these people realize what she's doing, where it's functional medicine, which the approach there is, let's try to find the root cause. It's not always medication first, even though she does prescribe medications for, you know, this, that, or the other. But it is a functional approach, and it's been cool for me to see when I go in there, some of the people that I'm, you know, sitting in a chair next to while I'm hooked up to an IV are, you know, not the people that are the same crowd that would be doing the same thing in LA. So no matter where you're at, this is being sought out, right? So what did I do today? I went in and quarterly I try to do blood panels and just do typical blood panels like CBC, cholesterol levels. We'll do trace minerals, B vitamins. Like today I added on a heavy metals test because we haven't done that in about a year. So I can kind of pick and choose, being a physician myself. But that's also based on what's going on with me. I also talked to her a little bit. We don't really do your typical visits anymore because we have a bit of a different relationship. In addition to the testing, I also did MHA therapy or ozone therapy. Basically, they take a little bit of your blood. I think she said 250 cc's of your blood, and then they mix in ozone, which is basically a gas. It's kind of funny. And she's like, a lot of people will say I'm paying money for that because they bring out a syringe that's empty, looks empty, right? It's got a gas in it, and they basically infuse that into your blood. And then you go on a drip IV, and I'll put an article in the show notes about like ozone therapy for what we know, the benefits it can have on like autoimmune issues, Lyme disease, cancer. But there's a lot of ozone therapy being used for performance, which is what I use it for. I don't know 100%. I don't think I have any of those things. But I'm just doing it for the wellness benefits. And she says that anecdotally, she's had a lot of patients that would choose that type of an IV therapy over like your typical like vitamin cocktail or vitamin C IV, which I've done out there also. So that's what I do, right? So it's not like I'm just telling you guys all this stuff like this is how I take care of myself. And she's a huge part of that. And I have, like we talked about last episode, I've had some health concerns, and that's who I went to. Super excited because she's actually moving closer to us, and she'll be more central into Birmingham. So anybody that's in the Birmingham area, if you don't know who she is, she's got a waiting list out the door for good reason, and it's only going to get longer when she gets closer to Birmingham. So I just want to kind of bring that up. In that same vein, before we get off on the first topic today, I want to talk about something that we're starting to transition more and more to here in the farm. And I won't give all the details yet, but we've alluded to some of the questions that we get online as far as like, you know, most of the questions that are directed to myself and my wife are going to be musculoskeletal questions. You know, I've got this injury, I've been dealing with this running thing, this gymnastics thing. But what I'm seeing more and more now, whether it's because I talk about it or people trust us in one aspect of their health, so then they start asking questions in others, is that they're asking about all parts of their health. And what we always try to do in here is look at everybody at the total human perspective and not just treat that musculoskeletal part, because just because you have pain in your body does not mean that that's caused by true physical pathology. And, you know, I had a good friend that reached out to me about some hormone issues. We're going to talk about a colleague that reached out to me about a patient encounter. Somebody literally yesterday reached out to me and, you know, just happened chance with what we're transitioning to said, do you happen to do total health makeovers? I would never call it that. I don't know. It's kind of funny. I had written down in this book just about a week ago, I said it's funny that like HGTV exists and that we have all these shows about home makeovers and home remodeling, but very few shows about like health makeovers or health remodeling, right? Yeah, we had The Biggest Loser. What did we find out about The Biggest Loser? It's probably the least healthy way to lose weight ever, right? It was just a competition to show pounds percentage to win money. There was not very much health involved in that show, but that's what the outside perspective of health is. It's largely based on body morphology and weight and counting calories and diets. That's a big, actually, I was going to say it's a small part of health. A big part of health is nutrition and diet. Even bigger part is all the other parts of being a human, right? Body, mind, spirit, work-life balance, relationships, all these things, right? And I am not an expert in all these fields, but I feel like, again, I've been able to learn enough about each to have a total human perspective on healthcare, and we're starting to help advise people. Another analogy I was thinking about the other day when we went to the lake this week, and we had an awesome time with a good friend that's a financial advisor. And when he tells people what he does, he says, I'm in wealth management. And I kind of, a little light went off my head. I was like, well, why don't we do health management? Why is it health care, right? Why is it, again, reactive instead of proactive? Why do we have a portfolio for our money and not a portfolio for our health, right? We dissect or we compartmentalize health to our specialists and let different doctors, because we know the body's complex, but maybe the complexity is built into the healthcare system rather than the actual organism, right? So the more that we dissect, the harder it gets to treat because we don't see how everything plays off one another. And the more that we look at how that pendulum swings based off of how your sleep could affect your nutrition, how your nutrition could affect your pain levels, how your work-life balance could be affecting all three of those things I just mentioned. If we don't look at those all together, I think we're always missing the boat. So if you have questions about that, DM me, Dr. Beau Beard. That's on Twitter, Instagram, Facebook. Send me an email at drbeaubeard@gmail.com. I'm going to be taking on more clients with that. We're building an entire program around this. Probably fall, we'll have this rolled out officially. But if you're wanting to get on board or if you have questions about your health, hit me up. All right. So let's get into one of the questions that I mentioned earlier that came from a colleague. I just want to bring this up because I think it's super interesting. He sent me a text, and he was like, hey, maybe the cooler part of this is actually how the patient got in his office. So he had a mom bring in I don't know if it was a young girl or young boy, I believe around 8 years old. They had been referred into my friend's office, who is a chiropractor, by, I believe, a neuro-ophthalmologist or behavioral optometrist. And they were at this optometrist or ophthalmologist, whichever one it was, because the kid was having problems with bedwetting. So let's talk about that really quick. Behavioral optometry is basically using drills to work on the mechanics of your eyes to affect neurology to have ultimately bigger output effects on your body. We do some of this in the office as much as we can and within our scope of practice. But I just thought it was really cool that, I don't know how they ended up with an optometrist, ophthalmologist, that somebody for bedwetting was there. So we already know that they're kind of on that alternative, outside edge approach. So the eye doctor, easier way to say it, just eye doctor, sent them to a chiropractor because they said, well, I think they could, help with this. And whether it was I don't know where the parents were educated with this or told this, but they were told that the child had what's called a sustained Gallant reflex. And I'll put in the show notes on our website, which will be chirofarm.com/farmmedia/bedwetting. That's what we'll title this one. I'll put a video of what the Gallant reflex is, which is a primitive reflex. Okay, and a primitive reflex is a reflex that is inborn in us. There's a handful, I want to say around 12 total. These are the reflexes that babies should, most of the times do, get tested on to make sure that neurologically we're doing okay at birth and then as we track along. And we may have a conversation on a future episode about child development, which we probably will. So I just want to touch on this a bit. But basically, the Gallant reflex, to explain it for those listening to the podcast, would be where we could be having or holding a baby via its stomach, so the baby's kind of facing down, and we can stroke its back, like its mid-back, and it's kind of going to arch, almost like it's getting tickled. We could do it with the baby laying flat on the ground. But that Gallant reflex is going to be present from birth up until about 12 months. It should go away. And most of our primitive reflexes, almost all of our primitive reflexes, go away. Some other ones that you're probably common with, like the grasp reflex, if you put your finger in a baby's hand, they'll grasp. That changes at about 3 months, changes again at 6 months. Most of us know or have heard of the Babinski response, so that's kind of that toe flick response. They'll do that with patients really on any neurologic exam. Do it with patients that are in a coma. That can tell us if somebody in a coma still has basically higher cortical function, if their Babinski response is still negative or at least apparent. There's a bunch of other ones. I may put another link to a resource, the Prague School, which does dynamic neuromuscular stabilization. They have a lot of resource on that, and that's why this colleague was reaching out to me, because I'm trained in that. So he asked, have you ever heard of the sustained gallant reflex, and have you ever heard of that as it associates to bedwetting? To be honest, I hadn't. So I know all about primitive reflex stuff, and so I went and did some research on my own. And what I started to see were there were a lot of videos out there from PTs and neurologists and some chiros on why this sustained primitive reflex could be affecting bedwetting. And it basically was just saying that if there's a primitive reflex that's still apparent after the time frame where it should go away, that there's some sort of like pathology or dysfunction. So I want to address that first. When we look at kids that miss developmental milestones, whether that's in the first 0 to 12 months or 2 to 5 years old, like maybe a kid doesn't crawl or they can't roll over on one side as they're hitting about 4 to 5 months old. These things will show up later. Some of these have true pathology tied to them, right? Like true upper motor or neurologic defects that are going on. Some of them are purely a function of environment, right? Lack of stimulus, too much stimulus in one preferential direction, right? How we set the baby's nursery up can affect all these things. But the sustained primitive reflex without pathology, right? Say a kid has had like a functional MRI or there's no other defect, there's just bedwetting occurring, and then when we go stroke this 8, 9-year-old, however they old's back, and they have this gallant reflex, you have to start thinking maybe it's more of like a processing issue or an integration issue than actually pathology. And this is what I was trying to kind of tell my colleague. And if we think about it different, it will grossly change our treatment. And this is no different, and this will make sense to people, I hope. If I'm very ticklish, that is not normal. And you may say, well, I've been ticklish my entire life. The reason that you are ticklish, and maybe it's only certain areas, if it's entire areas, we'll talk about that too. But let's say I'm only ticklish through my flank, right? Everywhere else, you're like, I'm kind of fine. What we know is for some reason, and you're kind of basically how you take proprioception or mechanoreception. That's like your input from tactile feedback, right? Somebody touching you, position of your body. That integration going up through your cerebellum and then ultimately to your motor cortex to how you would respond to it, there's some sort of default in the integration there. That doesn't mean anything's like pathologically wrong. It could just be like there's a little motor pattern blip there. What we know with those people, the reason you're ticklish is your nervous system is heightening the awareness in those areas where you don't have good integration or feedback, because that's the best way to keep you safe. Same reason your feet might be ticklish if you stick them in shoes all day and they lack feedback. And if I want somebody to desensitize their foot, what do? We have them roll their foot on a little spiky ball or like a dog toy looking thing. Because if I'm always living in that state of heightened feedback or ticklishness, or what we'll call a sick nervous system, and if we go off the full end of the spectrum, it would be called a full-blown central coordination disorder, right? We're not able to coordinate centrally, right, central nervous system, what's going on from the afferent or the input from our environment. So we know we need to desensitize those issues. Now, there may be movement pathology tied to that, right? Not injury, but like I may not move the same on my left versus my right, and that's why my integration's off. I'm not getting the same feedback. I have a joint that's extremely stiff. I missed one of those developmental milestones, all those things we talked about. So let's talk about this gallant reflex as that applies. So maybe, and this is more of a postulation where he's putting this into practice, and I want to tell this story because if you have a kid that's dealing with bedwetting, this may be a big part of it, and I truly believe it is. And there have been studies, which I'll probably link to one, about emotional trauma with bedwetting and things like that. Or, we need to make sure we can rule those things out, and those may be hard to rule out for some practitioners, but we should discuss those things with the parent and maybe the child as well. But let's say that's not the issue, and we test this galant reflex. Well, sure enough, it's positive. So what I coached my colleague to do was we can desensitize the area through basically skin stimulation. A lot of what we use, believe it or not, is like a hairbrush, right? Hairbrush has a lot of little spines that are close enough together to where your brain can almost read it as one unit, but far enough apart to where we're getting still our basically tactile acuity, right, or 2-point discrimination. So we would hairbrush all around that area where they have that ticklish response. It's kind of hell on wheels for the first 10 to 20 seconds, and then you'll see that sensitivity decreases. Now we're almost back to square one, right? That's what we're looking for, is the nervous system's like, hey, this feels like my back. I know this is my back. I don't have to heighten the response because I don't know what's coming in. Well, now how can I create long-term desensitization or just improved proprioception? Proprioception is basically position sense. Well, I could use something like kinesio tape or rock tape, and we'll tape over that area of the spine, right? And then what we want to do, if we want to increase tactile input, what we want to do is get the kid on the floor, right? So what I said is maybe before bed, we go through rolling patterns. I'll put a link to a video for what rolling patterns are, where we're basically just going through very primitive, easy trunk rolling, and then maybe some dead bugs, right, where I'm putting my spine against the floor and having to stabilize, because maybe the reason that we have this integration or central integration disorder that's leading to a confused signal is because I missed one of those steps. I didn't get enough afferent input rolling on the floor, maybe because I was put in a walker chair. I was held too much. I didn't spend enough time on my back. I didn't spend enough time on my stomach. Those can create blips of how you deal with your environment. It would make sense that if I put blinders on, I don't perceive my environment. If I don't move a joint or load a joint early in my life, it's just like putting a blinder on that joint, right? And that could be in your spine. That could be part of your skin. Your skin's an organ, right? So the easy explanation is, if I can't integrate, I'm confused in an area of my body, right? If I couldn't dictate what my wrist is doing, well, let's take that to the area of my body where my bladder is. Let's say I don't know what's going on and I'm asleep. We may say that maybe from a central nervous system standpoint, that kid is not picking up the response to go to the bathroom, right? So they're completely missing it because they don't have great feedback. It's just like if you never felt the urge to pee and you just look down and you peed your pants. That could be happening. Because what we also know about bedwetting is to actually have the act of urination occur is actually a conscious level act. That's why you can hold your urine. If not, we would all just be peeing all the time. It's a conscious level act. What is subconscious is the feeling of micturition, the sensation of having to pee, right? And if we don't have that sensation, then we may not have a conscious level response. Now, I know that's a lot of big, heady words to basically explain, like, the kid's nervous system is confused, they're not getting the message to go pee, and all of a sudden they pee in their bed. There's a very high likelihood for this. Now, this doesn't mean, and this is why I was explaining this, I don't think this is necessarily tied to a sustained galant reflex. What I think should be researched and looked at is, are these kids, do they have like a sick nervous system or central coordination disorder overall, right? If you went and tickled their feet, or if you had them do some cerebellar or basically integral like space coordination tests, right? Like drawing circumferential circles on both sides of their bodies, showing you how wide their shoulders are and trying to flip it head over heels and then bring it back. Like, are these things normal or are they off? And I would almost guarantee, I can't say I guarantee because I don't think studies have been done, you're going to see it's not these sustained reflexes. They have integration disorders overall. So easy ways to fix this stuff, and then why I'm saying this is because we need to stop telling people that these are pathologic things. It's probably not pathologic. This is a movement disorder. That's not a pathology, right? It just means you missed a step. We got to go back, reintegrate, or we just got to desensitize, all right? If you have questions on that, let me know, but I'm going to try to link to some articles, some videos, some ideas of what we could do. Maybe I'll dress like a giant baby, and I'll have Dr. Sloan work on me, and I'll show you how I would desensitize my skin. She's frowning. I don't know why. So that's not one of your fantasies, seeing me dress like a baby? Okay. I don't know, guys. Whatever. But maybe I'll show how I could desensitize somebody's skin, tape, and the couple drills. Maybe we'll put a little video together on that. So if you have a bedwetter out there, hopefully they're not like 25 years old. Hopefully we're dealing with like an 8, 9, maybe 7-year-old. We can help them out. But if you're 25 and you're wetting the bed, sans alcohol, maybe this will work for you too. Okay. So let's move into our viewer Q&A. Our viewer Q&A for this week was sent in by Alex. And let's go ahead and take a look at that.
Hey, Beau. It's Alex. Got a question for you. So as a college student, I am often asked what I'm going to do after I graduate, and I say that I'm going to be a chiropractor, go off to chiropractic school, to which most people respond with, well, that's great, you can help me to get my bones back in line or put my hip back in. So my question is, I don't necessarily know how to respond to that because I want to do way more than that, even though those are misconceptions anyway. But just to keep it brief, how do you guys explain how you practice to other people in the general population who may or may not really know what you guys do in your office? Because it's far more than just an adjustment. And I know that I can't just explain what an adjustment is to everybody, but I just wanted to get your thoughts on how you go about answering that question for yourself. All right, thanks, Beau.
All right, so thanks, Alex, for sending that in. And by the way, like Alex said, he's getting ready to go to chiropractic school. He's going to our alma mater. I would say he's going to be a llama, which it should be, but they created it the Jaguars for a mascot. It's so stupid. Whatever. But he's going to chiro school, so hopefully he'll be coming back to our area. So we got more smart cookies around the Birmingham area. But this is a really common question that we have to deal with. Obviously, you're already dealing with it. You haven't been in school yet. But basically, let's attack this in two fashions. Let's address the semantics issue first, right? Are we putting bones back into place? Are we popping a hip back in? The answer is no and no and no and always going to be no, right? I love my patients to death, but like we even had a patient call in the other day, and they said when my elbow's out or I got a first rib out, I always picture the game of Operation, like somehow like their first rib popped out on the floor and they're gonna bring it in and I have to strategically put it back in before something buzzes at me. And what we have to realize is it may just be patient semantics. That's all it could be. Who cares what you call it? Let's fix it, right? But sometimes we do have to educate people on the fact that I'm not putting your first rib back in because that builds dependency that you need somebody to adjust you, right? Or do soft tissue on you. You don't need these things. I promise you that. There are people that live their entire lives, whether they were very active or not active at all, that had no manual therapy. They did just fine. Maybe we don't know 100% why, but these aren't needed. They can be very helpful, and sometimes if you're in enough pain, it's super nice. But at the same token, this stuff didn't always exist, right? There's always been some form of body work, but not in all parts of the world. And I can promise you one thing, even though we have, there's records, anthropologic records of arthritic tattoos and things like these where they used to tattoo certain areas on joints for pain relief, there weren't chiropractors running around, putting first ribs back in when people were Neanderthals. There weren't people cupping, via suckerfish, 5,000 years ago. These things didn't exist and people did okay. So we're trying to not build dependence. Now let's talk about the other part of Alex's question, or actually let's address the second part of that. What are we doing if we're not putting a first rib back in? Usually, like we talked about earlier in this conversation with the bedwetting, it's a lot of regulating the perception of the nervous system, right? Trying to nullify pain through some sort of tool or tactic. A tool or tactic for pain desensitization or regulation could be anything from an adjustment to cupping to soft tissue with my hand, a tool, talking to somebody, explanations, education, exercise. There's a ton of tools for reducing pain. There's also a ton of tools for improving joint range of motion, muscle elasticity, muscle strength, fluid dynamics, right? How my lymph moves, how blood moves. All these things can be affected, right, by different tools and techniques. If I had to say what we do in our practice, right? So if I'm not putting something back in, I'm modulating pain. I'm changing movement, right, via exercise and corrective exercise and education again. What we're really doing, first of all, going all the way back to the beginning of the episode, is managing an entire human's health. Not like I'm not giving out drugs. I'm not necessarily telling everybody what to eat. I'm trying to make sure that I understand what's going on with this person's entire life to make sure, A, why are they hurting in the first place? Which a lot of what we deal with is I hurt my shoulder doing a exercise, so we have to modulate pain, change movement, and then reinforce said change movement, right? That's rehab. The other part of that is not creating dependency, educating people on what's really going on with their body. That's what people don't know, right? If I could ever get smart enough to write a book called the Manual of a Human, right? Like the manual of your Lexus out in the parking lot. I don't have a Lexus, by the way. I have a Nissan Rogue. It's a very nice car. I didn't need to read the manual, though, because it's not that complex. What is complex is a human. But if we could write a manual, it would have a lot of these things in it, right? How to move, how to eat, how often do these things, what do I need to be healthy? That's what we're really doing. 3 years ago, this explanation of what I did in my practice would have been very different. I would have said, I try to improve performance in athletes. That was kind of like, we were always trying to think of what's that 15 to 30 second elevator pitch, right? Like if somebody comes up to me, what do you do? One of my mentors in the sports rehab world always used to say, like, I'm tuning Ferraris. And they'd be like, what are you doing? And you go, no, I work with high-end athletes. Like, because he wanted the next questions. Well, I'm not trying to sell anything. And my elevator pitch doesn't need to sell anything. It needs to tell the truth. My elevator pitch is I'm taking care of total human health. I may only be one part of the team, but every part of that team needs to understand total human health. Otherwise, A, they're probably not going to be part of my team. B, we're running into that dissected, reductionist view of healthcare, and it creates frustrated patients, it creates poor outcomes, it creates elevated healthcare costs. And this is the thing that we're staring down the barrel of every day now. And we're trying to offset that a little bit through creativity, right? Creating more virtual experiences for people, creating more streamlined, education-based experiences between us and our patients in the office here, right, in a physical location. Yeah, we still adjust people, do soft tissue, do exercise. But the one thing that I found myself saying more and more often in here is, I do not want to see you again for the same injury. Will it happen? Yeah, somebody's going to go out and sprain their ankle again. That's fine. That's an acute injury. What I don't want to see is that I've educated somebody on, low back pain. They hurt themselves doing a squat, and lo and behold, a year later, they come in and they hurt themselves doing a squat again. Well, that's not necessarily an acute injury, and you may say, well, yeah, it is. They hurt themselves loading their spine. Well, if I've taught them or maybe intervened and we got them moving a little different, moving a little better, if we want to use better as a descriptor or not, we've loaded their system, we've educated them, I don't think we should run into an issue unless something completely unforeseen happens. What I don't want to see is that I run into somebody at Home Depot, and they are like, I haven't been able to squat for 6 months because my back still hurts. Like, that's not me doing a good job, right? That's me just being run-of-the-mill, which that is not my goal. So it was a very lengthy answer. I don't have an elevator pitch anymore. I take care of total human health. And then somebody'd say, what's that mean? Well, come have an hour conversation with me, right? That's what we're doing. That's how much we need a bunch of info, because to think, this is what I'll wrap this up with today. It baffles me to think that I could come into somebody's office and I've never seen them before, and in the window of 15 to 20 minutes, you're going to tell me everything that has been happening with you that led up to whatever pain is happening to you right now. And we're just talking about musculoskeletal pain right now. And that I'm good enough as a practitioner to figure that out in 15 minutes, treat you, have long-lasting relief, right? And I did that in an efficient and economical way where it benefits both patient and practitioner. Like, bullshit. It ain't happening. And if it does happen, somebody's getting taken. Whether it's a give or take, the practitioner's giving away too much of their time for too little money, or you're giving away way too much of your money for too little of a practitioner's time. Both are happening. I think you know which one happens more often. So I hope that answers your question, Alex. Please keep sending in those Q&As. You can email me a question. You can, like Alex today, you can shoot a video. You can voice record it. These Q&As fuel my thought processes for these videos, especially when it's like myself or the Beards, or if you have ideas for future guests, somebody you'd like me to interview, whether it's here in the Alabama, Birmingham area, or if it's, nationwide or across the world. Send me ideas. As always, I appreciate you guys listening, watching, and I'll see you next time. If you enjoyed this episode or any of the episodes, please subscribe via iTunes. That always helps kind of get us up there in the iTunes rankings. Also, leave us a review. Again, I love a 5-star review, but whatever review you got, I'll take the constructive criticism. Again, that helps pop us up in the iTunes rating so we can keep spreading the truth. Thanks, guys.